Okay, good evening, everyone. Thank you so much for coming out this evening. So first of all, I want to acknowledge that this whole lecture series is being sponsored by Yechiel and Yael Reis. This is not their first rodeo, as they say. So a big yasher koach to them and to the family. This is being specifically done b'schus refuah shalema, so it's very appropriate in terms of the topics. The refuah shalema should be for Sarah Gittel bas Mirol, Aaron Elimelech ben Brendel Leah, Mirol bas Sarah Gittel, Bluma bas Masha, and Yehudis bas Fega. So they should all merit a refuah shalema. It sounds much better in Yiddish when you say the expression which says, before I will speak, I would like to say a few words, but we'll make do with that. So a couple of important introductory comments before even we get off the topic. The first and most important thing is that in the capacity that I'm speaking today, I am not giving any psak halacha. Nobody should walk away in any way thinking that what they're hearing tonight is any psak halacha. I will share with you things that I have been privileged to hear and learn from my Rebbeim, but essentially all questions, especially on these important topics, are going to be directed to the Moreh Hara, the Mordaster of our shul, and that goes without saying, very, very important. Now, we should begin with just an understanding of, you have some notes, and I'm going to try to follow that a little bit. The topic that I prepared is, in retrospect, just too large to be able to cover. I mean, this could be a series on its own, maybe next year. On the other hand, in terms of doing this, there are several different ways of approaching this, and I was thinking about different ways. One is to give a shiur. So the shiur basically goes through with Mari Makomos and sources and things of that nature. The advantage is that you get to learn it basically much more in depth. The disadvantage is that you can't cover ground, and you get bogged down in a lot of the technical details and the learning of the words. And then to go the other way, which is just to basically just give a lecture, has merit, but it doesn't have the substance as much as possible. So somewhere between the two, I'm trying to dance between the two, and I am going to primarily focus on to try to cover ground, because I want this to be topical, in the sense I want to cover as many topics as possible, and where needed I have some key references. But anybody that wants any of the Mari Mekomos specifically, I have a separate sheet of Mari Mekomos that are, that go into this discussion, and happy to share those with you at a later time. So there are lots of topics here. A couple of things that we're not going to talk about if you thought we were. For example, MAID. The medically assisted, here in Canada, in medical assistance in dying. It could be a topic on its own, but it's really not, because it's a one-word answer. No. How simple is that? It's usher. It's there's really no heter whatsoever. So we'll just move on, and we're not. And again, in terms of so I'm just dismissing that right now. It is something. Who to do it? How to do it? It comes up, but again, a separate topic altogether. Some of the other things that we won't be covering is a very critically important topic, which is the time of death. Okay, which is the two major approaches, which is one is cardiac death and one is respiratory death, and that is for sure a topic on its own. So that we have to just we have to leave that on its own, because that is just too great of a topic, and we'll just leave that and bypass that. The other topics that you have in front of you in the outline, we'll try to cover them as much as possible, and you'll see that there's going to be an overall theme to where we're going to go. Now, by way of introduction, why on earth would I have chosen this topic? It sounds like a very, very, very morbid type of a topic to discuss. But in thinking about it, I'm sure you'll agree with me that in our lives, we deal with the following scenarios. So whether it is buying a house at some point and consulting our lawyers and real estate agents and creating a business, you have to speak to tax consultants and things of that nature. There used to be a time perhaps that a person would just simply say, "You take care of it for me." today, I think most people are interested in the topic, but at no point in time, at least for myself, do I pretend that I'm the accountant running my office. And I don't ever want to be the accountant that runs the office. In other words, I have an accountant, but I do find that if I learn a little bit about the topic, I can understand what they're talking to me about, number one. I can ask better questions, and I could be better informed. And I think the analogy is just so obvious. Here, we could take the approach which is, it's not in my hands, I don't need to worry about it when the time will come, and I don't want to give myself any ayin haras or any things of that nature, and we'll go from there. And that seems like a very, very myopic approach to the way to do it. On the other hand, nobody should leave this room thinking, oh, great, I heard a lecture/shiur on this topic, and now I'm ready and equipped to be able to deal with all of these questions. So that it goes without saying that is the thing. I think we have to balance this idea that there is, there's sanctity in human life, and we have to be able to respect that. And then we have to also balance halacha. And what does that mean? It's not a balancing act. That's one. In other words, it should be symbiotic. They should be essentially one and of the same. And when we go to these type of approaches, they are one and the same. So this will help guide for us these complex medical decisions. If we understand them a little bit better, so then there will be essentially an interplay between the professionals that are going to be involved. There will be, of course, the family, there will be medical professionals, and there will be hopefully someone in the rabbinic, sort of family to be able to say, these are some of the guidance that are there. Now, this is something which, again, everyone says, it's by yenim, it happens to the others. Unfortunately, here's a fact of life. We're all going to die, and the overwhelming majority of people are going to die of a cardiac death at some point. And that is just the reality and the facts. That's how people die. How it happens and what's going to happen along the way is what makes it much more complex. But it applies very much to everybody. And it's not, looking around the room, there are many that are going to be in a situation where they're thinking about their parents. There are things that, you also have to perhaps think about, like the median age here, maybe it should be dropped by 20, 30 years and thinking about what about, other type of, decisions, what about, our, the younger, what about our children? What about thinking about those type of things? So I think that there's a taboo about this. There's a lot of ayin hara. There's a lot of discussion, and nobody wants to discuss it. And thinking that if you don't have to deal with it, then we're better off. But that's, by way of background, clearly not going to be the way to do it. So this is trying to impart upon all of us the need to go through this in a systematic fashion. So as I've already pointed out, but just to be clear, the majority of what we're going to hear tonight is, I'm happy to say, and I'm looking around the room, and many of the people in this room have been, participants in medical conferences where we heard Mori Rabbi, Rav Steinberg. We've heard from great poskim. I've been to so many years of conferences with Rav Steinberg, Rav Asher Weiss, and Rav Aaron Glatt. And this is really a sort of a way of putting this all together from all the years and trying to put it together in some way where I can pass this on. But each one of these topics is large and was dedicated with this amount of time. So everything I'm saying today comes essentially from that type of a background. Now, let's get into it a little bit. So some of the challenges that we face today are the following. There are 4 principles that are known in medical ethics, and people spit them out in terms of like rote memory. They are basically, the first one is benefit. So benefice. In other words, the idea of that there has to be some, in the Latin term beneficence is the term that essentially says that there needs to be a benefit for doing something. There has to be a good reason to do it. The opposite of that is the non-maleficence. In other words, you don't want to do any harm. And any of us in the medical profession know, do no harm. It's the first rule of medicine. Before you even begin to treat a patient, first do no harm. There is a concept also called autonomy. And the autonomy means that the patient has some degree of control over what they or want. But to show you where the complex, where we have some challenge is as follows. Patient comes into the emergency department with a headache. The autonomy of the patient says, I want X or Y. I want an MRI. The doctor says, well, hold on a second, I don't think it's indicated. You don't need an MRI. So how do we then apply the two principles? One principle says the patient is autonomous and the patient wants something. On the other hand, we're guided by, is there going to be a benefit? And certainly we don't want to do any harm. Now that's a very simple example, but then you can add to that when you sort of say, well, the patient wants a surgery, a patient wants a treatment, and their autonomy sometimes is going to be at odds with what the medical profession will want to dictate in terms of some advice. And the fact is that autonomy, if you look at the pendulum, how it swung, medicine was very, very paternalistic years ago. And over the years, it has become extremely autonomous. In other words, now we, the medical professionals, are almost at a point where we're saying, we're giving you advice, here's the menu, I'm here to serve you. That is the approach. What would you do, doctor? I'm not here. Here's the menu, you choose. You want French fries or you want you tell me what you want. You give the choices. You can add to the layers of that, but autonomy is now the driving factor. Now, if autonomy is the driving factor, then you start getting into issues where does halacha fit into this here? So halacha has an interesting approach to this. Me'ikar adin, so to speak. In other words, if you look at the classic, the older of poskim, in terms of autonomy, there was never autonomy was not something that was thought of in terms of halacha. In other words, this is what you need to do. In other words, there are rules about how you have to treat yourself and when times you can treat, when sometimes you cannot treat. So there's halachas of Shabbos that will limit the amount of treatment a person is going to get. There are times that we have to treat. And the concept of saying to a patient, you need to be treated in the year 2025 is essentially something which is unheard of. Who would ever say, what medical, you need to be, I will impose this. Yet, if you look at some of the classic poskim in Hilchos Shabbos, classically the Moruk Tzia talks about even forcing an amputation on a patient. And this shiloh was again recirculated even with the Tzitz Eliezer, Rabbi Lazer Waldenberg. Now, you have a patient who's a diabetic, and you have an individual who the doctors say, if we don't amputate, you're going to lose your life. But the person who you're amputating the leg from happens to be a pole vaulter, or whatever the case may be. Happens to be that they have now either a cancer, Ewing sarcoma, or something that mandates that they have to amputate the leg. The patient says, for them, that, if they can't do pole vaulting, then they don't want to live. So halachically speaking, the halacha says, what are you talking about? His life he has no option to do that. So that is the extreme position where halacha seems to go in. Rav Moshe comes in in his tshuvas, and we'll discuss the context of this here, because he would not necessarily agree with this principle that we just laid out in the case of a terminally ill patient. Now we'll define what terminally ill patient is in a few minutes in more detail, but we clearly have to see the difference between the example that I'm going to use. So again, for my world of the pediatrics, you have a 17-year-old who has a Ewing sarcoma, means a tumor of the bones, and they are a pole vaulter. As I said, if they refuse treatment, no posek would say that would be halachically, because you can continue to live. There's a very big difference between that scenario and the scenario of an individual who is at the end of stage of life who wants to refuse or to withhold on treatment, which we will spend the bulk of our time. But I want to point those out. So when people quote the Moruk Tzia as being definitive in terms around that there is no autonomy, it's pretty much across the board. What Rav Moshe introduced to us was this idea that autonomy comes in at later stages of life. When I say later stage, it could be at a very young age, but it could also be at a point where a patient is much more terminal. Now we have to get into that definition. So, again, Steinberg defines terminal, like people say, who is the dying patient? So he's not joking when he says you're dying the moment you're born. Think about it, right? In other words, the moment you are born, you are a dying patient. That's what you are. So as soon as you're born, you're in the process of a long process. So what does it mean that you're the dying patient? Like, at what point? A year, 6 months, 9 months, 12 months, 15, like, do you count it by months? Do you count it by years or things of that nature? So it's a bad term, this idea of using dying patient. Is it better to use the term terminal patient? It doesn't, again, define it for us yet. So we'll get to that in a moment. But I want to just address one other point, which sometimes I don't think it gets enough press time in we'll call Jewish medical ethics, or in this thing here. Is there a concept of a good Jewish death? Okay? So is there such a thing? Or in other words, does such a thing exist? So I'm going to share with you two sources that I found that I will make the argument to say that absolutely there is a concept of having a good Jewish death. And that is the following. Moshe Rabbeinu. At the end of Parshas Deva, at the end of the Sefer of V'zos HaBrachim, towards Hashem tells him that you are now, you've reached your days and you will die. And the pasuk tells us Kasher Meis Aaron Achicha, just like your brother Aaron died. And this is one of these sources I did want to choose to look to have inside. If you have it with you, I'm on page whatever it is, but you'll find it there. And Moshe Rabbeinu basically, Hashem tells Moshe, you're going to die the way Moshe died. Seemed the way Aaron died. And what Hashem was telling Moshe was, you seem to have an interest in the way Aaron died. Let's look at that. So look inside with me. I'm going to read this in the Hebrew. The misa, the death of Aaron that you witnessed, and it became something that you wanted, you desired it. What was the story? Shehifshit Moshe es Aaron beged rishon. Moshe took off the first layer of clothing from Lazer, his son, and then the second one. I'm just going to paraphrase a little bit, and then he essentially disrobes Aaron. He has and he places it on his son Elazar. So first of all, what we see right away is the notion that having children and the ability to carry on is something from a figurative and a mental perspective, something that is highly, highly praised and highly valuable. Now, the idea to watch your progeny continue along your way gives a lot of sense of nachas to the individual. That goes without saying. And basically, Moshe Rabbeinu goes through this thing with Aaron, where he tells Aaron, "I want you to," and the following steps. He says, "Step up on this table here, and I want you to open your hands." And then he tells him to close his legs, and then close your eyes, close your mouth, and he does so, and then Aaron passes away. And Moshe Rabbeinu's his approach is, Ashrei, he says, Misha Meis B'Misazu. Moshe Rabbeinu tells us this is the perfect death. In other words, you watch your children be able to flourish in that position that you had. You were Aaron was the Kohen. You passed on the gauntlet to Elazar, your son, and there's no pain. And constantly in Chazal we refer to something called Misas Neshika. This is a different. Misas Neshika is you just basically go to bed. This one here is planned. A second source I found recently, coming across when we were learning our Mishnayos, is a fascinating Gemara, which tells us it is a mitzvah, v'ahavta l'reacha kamocha. There's a mitzvah in the Torah that is called v'ahavta l'reacha kamocha. And the Gemara says, you know what that is? The people in the courts, in the Beis Din, they had a special mitzvah of v'ahavta l'reacha kamocha, and the expression in the Gemara is beror lo misa yafa. Choose for that individual a better death. Now, what does that mean? Here we're talking about when there is someone that comes to Beis Din and they committed a capital crime. There are four deaths that the Beis Din gives: skila, sreifa, hereg, and chenek. Don't have to go into the details, but basically there are four types. There is a difference in the pain that a person suffers at these ones. The Gemara tells us that the Beis Din was always to look to give the one that is the least, that is appropriate. In other words, they're from the highest to the lowest, the machlokas, which ones it is, not important, but the point of it is, beror lo misa yafa. There is a concept to say that there is a proper way to choose, to die. So, in order to get to that point of being what we're going to call terminal, we need some definitions. So the first definition that we're going to talk about is something called a goses. A goses is something that existed in the past. Does it exist today? Of course it exists today. A goses is someone who is close to death. But how do you define it? Ironically, it was easier to define it without medical intervention. In other words, if you ask someone who works in the Chesed Shel Emes 50 years ago, 75 years ago, what's a goses? They'd have no problem telling you. Because what did they do? They would go to the bedside countless times, and they would see people, and they would say, 2 days, 1 day, 3 days. You knew it. There was nothing else. There was no medical intervention there, so there was the understanding. But today, you go to a hospital bed in the ICU, 84 monitors, 22 lines, 12 patients. How do you know what's going to be? The best of the doctors can barely predict such a thing. So the irony, says Rav Moshe, is that the goses that we have today, we can't define it. Now, why is it important to define a goses? Because one of the paradoxes about a goses is there's things that you cannot do. First of all, a goses is alive, halachically, but you're not allowed touching a goses. So you can't intervene to help a goses because the thinking is that that goses is so close to the end. But hold on, but that's what isn't all what we're going to be discussing later on tonight? Terminal, it's the end stage. Well, how is that going to be a goses? So that is the difficulty. Goses is a term that essentially is an older term that was used with some level of precision. And Rav Moshe basically says that level of precision is lost. The irony of it all, the more medicine we have, the less we can rely on this idea of what is a goses, because it's difficult. You can't predict anymore. And if you increase the pressure agents on the patient, that means the way to keep you can keep blood pressure going now. Again, not forever, but a few more hours. It comes a point when, yes, of course, the patient will die. There's no question. But the point being is that a day, 2, 3, 4, a week, it's very hard to predict. So that is called a goses, and it's important to know that halachically, the rules of goses is you cannot treat. You cannot treat. You cannot touch the goses. You can't close the eyes. You can't. So most of the halachic discussions that we are going to be entertaining cannot be discussing a goses, or by definition. So what definitions are we going to use? So we're going to use a term called chaye shah. Now we'll explain to what a chaye shah is as opposed to chaye olam. Now, again, the text and the background is beyond the scope of this evening, but the story is from the Arba Mitzrayim, the 4 that were Mitzorah. They had the Navi tells us they were the children of Gehazi, and again, we will have to just leave that. But the point is, from that story, the Gemara derives this idea that there's something that is which we're going to call chaye shah. Now, chaye shah is the closest that we're going to have to what we're going to call a terminal patient, or a dying patient, or a patient in that process of dying. Now, chaye olam, of course, is going to be much longer than that. That's going to be. So back to the case that we said before, just to use 2 paradigms. So if you have a 17-year-old who has a whole life ahead of them, but has Ewing sarcoma, and now the treatment for this Ewing sarcoma might be to amputate, is that patient now going to be called a chaye shah? So the answer is absolutely not, right? Now, we haven't defined yet how long it is, but let's just say, is that a terminal patient? No. That patient is not a terminal. There's a treatment option. On the other hand, a patient who makes no difference what the age is going to be, because I'm going to show you later on that age is not a factor in this at all, but what is a factor is going to be is how close one is to the end. Now to make a medical decision is going to be much different than what we had before. So I want to stress this point because it's going to come up multiple times. The only discussion that we are having this evening, when we're discussing withholding or not withholding treatment, options of treatment, only apply to a person who is defined as a chaye shah, right? In other words, it cannot be anybody else. In other words, halacha does not give that type of latitude. Autonomy does. So when an 8-year-old girl from one of the Indian reservations decides they don't want chemotherapy, the province of Ontario did not push it and let her die. In other words, she didn't want it. She's 8 years old. So that brings up all kinds of crazy questions. Autonomy, but how old? At what point can you make that decision? And who's going to make that decision? So, and yet that is when autonomy is taken to its limit. But this whole conversation that we're going to have from here for the next half hour is got nothing to do with Chaye Olam. It is strictly Chaye Shah. So we need some definitions then on what Chaye Shah is going to be. So the Chaye Shah argument is essentially that we look at where do we see it at all? Do we have it? So there is no reference at all in Shas. In reference, what we have is something which is for an animal, and that is called a treifa. A treifa is an animal that when the shochet does the shchita on the animal, they open up the animal and they say, aha, this lesion will cause this animal to die within 12 months. That is called a treifa. So essentially, the poskim have decided that they are going to use 12 months as the limit, and we'll call that a treifa, and we'll make the assumption that a treifa is a chaye shah. Now, Rav Steinberg told us that in Israel, what they decided to do, that they opted essentially that they use 6 months, not 12 months. And the reason that they use 6 months is for the following reason. And it's very logical. In other words, the halacha is at 12 months. How well can you prognosticate? So in other words, let's say a person comes into the office, they're diagnosed with pancreatic cancer. So what's one of these horrible cancers that in general, in the past, they would say approximately 6 months to live. Now, is that person going to be a chaye shah or a chaye olam? Makes a big difference in halacha. So if you prognosticate and you say 12 months, then that individual, you have to then say, if they're going to live 12 months, then all of the medical decisions, all of the halachas that we're going to discuss now are not applicable because that person has a lifespan of more than 12 months. So in Israel, when they wrote the law, which is called the dying patient law, the Israel dying law, then Rav Steinberg essentially put forth that it should be at 6 months because that gives better prognostication. And if they're wrong, that's okay too, because all you're doing is you're going to be within the 12 months. So you can prognosticate better, and you have that leeway that you're always going to be within the 12 months. So very, very ingenious how they came up with this. So in Israel, it's interesting. And Rav Steinberg tells the story all the time. He says he never talks about halacha when it comes to the Knesset, because that's a lost cause. But essentially, if you bring this up as a medical ethics issue, and you bring medical ethics, and it happens to fit with halacha, then it's much more likely that it will sort of see the light of the day. And that's what it is. Okay. So we come now to one of the buzz terms that is in the world today, which is quality of life. Now, what does quality of life mean? So, again, to a 17-year-old pole vaulter, it's all about the pole vaulting. That's the quality of life. What's the quality of life at a different age? So everybody will have their own set of, their own mindset as to what is quality of life. What is that definition that says this is good for me? But you have to also remember that when you're 20 years old, right? A lot of our 20-year-old children look at what we do at the age of 50 and 60, and they think, well, that's not really much of a life anymore. So, so you have to understand that you can't make a decision, too many years in advance when you're thinking about, what does end of life be? So if a person, is sitting at home, is in a wheelchair, can't move, and things like that, there may be an inclination for a younger person to say, I'm out, take me out, right? Not that you can't, but the mindset is going to be along those lines. But quality of life becomes a very important issue. So in terms of the quality of life, that is something that we have to always look at. And one of the points I want to always raise, and this was raised again by many of the poskim, is what about age? So one of the things that always comes up is, patient comes into the hospital at a certain age, and as soon as you come into the hospital these days, the first question they ask you is, what? DNR. Okay, yeah. So that's the very first question, after do you have an OHIP card, right? So do you have an OHIP number? Yes. Okay, your second question is, are you a DNR? So, and as soon as a patient is older, and however you define today older, then, so one of the principles in terms of quality of life is that age has nothing to do with it. In other words, halachically speaking, a person who is in their 70s, in their 80s, their 90s, and if they even reach 100, that should not be a dictating factor for the issue of medical decisions to be made. That's an important principle laid out, and Rav Moshe talks about that. He says even a zaken muflag, in other words, even a great, now whatever that means. So, life expectancy, if you're way beyond that, that's an important issue to keep in mind. So that's going to be. Now, here we get to the crux of it. The topic of the lecture shir is halachic perspectives. Now, why would I have chosen to say halachic perspectives? Why didn't I just say the halachic perspective of end-of-life decisions? And that is because, essentially, this is not going to be a uniform, this is it, this is the only way to do it. There are approaches that we have to respect. Now, speaking to an audience, here today, I mean, there may be, I'm going to make assumptions that perhaps we're more comfortable with one side of the coin versus the other, but it's important to recognize that halachic perspectives means, and I'm going to show you two just broad type of goalposts. The first approach is the value of life is infinite and absolute. Now, this means what? That every puff of air that we breathe is in some way infinite, magical, wonderful, and I'm not trying to minimize it, I'm not trying to in any way, but that's what it is. It's chiyus, whatever you want to bring in, Kabbalah, whatever it's going to be. And therefore, there is an obligation to prolong life as long as possible. Every second counts. And there are many sources that you can bring for this, that you could talk about. That 1 minute in this world is better than the whole world of Olam Haba. Again, difficult concept to understand because we think of this as this world as being the prosdor. This is the passageway to the Olam Haba, and that's what we're all doing it for. And yet, the Chazal tell us that 1 second in this world is greater than all of Olam Haba. So again, sorry? Okay, I mean, again, but again, that is, the point being is that there is, a tremendous amount of literature to be able to say that every moment counts. The classic poskim, for example, the Tzitz Eliezer, so who was of this opinion? So the major opinion is going to be from the Tzitz Eliezer, and more contemporary is Rabbi Bleich in New York. And basically, they will tell, and this is not two individual. This is a school of thought. I'm telling you, these are the two most prominent in terms of their writing. Tzitz Eliezer, Rabbi Lazer Waldenberg, the Rabbi of the Shari Tzedek Hospital, basically a Bucky in medical ethics, has written a Tzitz Eliezer, which we use all the time in terms of being able to learn halacha from. But the Tzitz Eliezer and Rabbi Bleich, contemporary at Yeshiva University, they've written extensively on the topic, and essentially they are the proponents of this concept. This concept we'll talk about later on, where you will get agencies and you're going to get people in contemporary askanim that are going to work with that, which is an idea that says everything goes. There is no such thing as not discussed. Whatever the doctors want to say, you just ignore them. We have to continue doing everything possible, no matter what, under all circumstances. I think you get the point. It's just full steam ahead. The other extreme is going to be, shouldn't be the other extreme, that the value of life is important, but it can't be infinite. And here you have what we will say are the mainstay of the poskim, the contemporary poskim. So we have Rav Moshe Feinstein, Rav Wozner, Rav Shlomo Zalman Auerbach, Rav Avad Yosef. And essentially, they are of the opinion that, granted, life is extremely important, but we have to put some limits to that. And it's worth reviewing what they base their story on, okay? Because we're going to come back to this at all. The story of Rabbi Yehuda and his death. Rabbi Yehuda Nasi died. The Gemara tells us this in Gemara in Ksubas. And the Gemara tells us that Rabbi Yehuda Nasi had many, many ailments for many years of his life. And then later on, it was at a point where he was feeling very unwell. And he was essentially in the throes of death, close to the end. The story is told that the Talmidim were davening for him constantly, and the Rabbi, Amsei de Rebbe is the maidservant of Rebbe, saw that he was, she took care of him, and she sort of looked, and she was his caregiver, and she said, "Oh, he's suffering terribly, and yet these Talmidim are davening for him, and they're keeping him alive." So the Gemara in more detail goes, that it was a struggle between the Elyonim and the Tachtonim, and it was back and forth. But the bottom line is, she goes up to the roof, takes a jug, throws it down on the ground. Everyone turns around and says, "What happened? What happened?" They stop davening. Malach HaMavis comes, and Rabbi Yehuda Hanasi passes away. So this Gemara sounds like an Agadita, but the Ran in Nedarim, Daf Mem, paskins that this is the halacha, and he talks about, which if we have time at the end, the concept of praying for someone's death. That's the thing. But more importantly, is that the halacha, the Gemara, seems to support this idea that there is a concept that we have that we want to limit a person's suffering. So if you see some of the quotes here, so Rosh Shlomo Zalman Auerbach and Rav Moshe Feinstein, very similar, but there's a huge and an important subtle difference between the two of their opinions. So they base it on the story of Rabbi Yehuda, and Rosh Shlomo Zalman Auerbach, again, we have all the sources, we can go through them inside, but basically would say you may withhold treatment if the patient is in, what are the two criteria? Pain and chayesha. Rav Moshe, using the same thing, changes the word slightly, and again, you have the text, that it is forbidden to prolong death. In other words, according to Rosh Shlomo Zalman Auerbach, a person would be, and this is where he talks about tshuva, to your point. He says, Yafa shah achas b'tshuva shekanu Allah. Right, that's true. If the person wants to do it, then that would be the source for it. If he wants to, that Shlomo Zalman writes right there, Yafa shah achas, if he wants. But Rav Moshe takes a much more stringent opinion and says it's forbidden to actually, and one of the lines that I found actually, very prolong life, but don't prolong death. That is the concept of Rav Moshe Feinstein. So Rav Shlomo Zalman Auerbach and Rav Moshe were very, very similar in so many different Piskei Halachas, but the principle here is that there is a fine difference between the two, which means if you ask the individual, they would have that option to do it. But both of them are in the camp of there's value, but at some point there's not. Rav Hershel Schachter takes it even a step beyond that, and he would make the case that essentially, what we do is what we would have to ask reasonable people. Now, this is very, 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 again, it's a discussion on its own, and I really don't want to go into details of it, but because, again, to go into Hershel Schachter, the problem is that if you ask reasonable people, the problem today is that I don't know where reasonable people are. Because you're getting teenagers that are making decisions that are, they're not reasonable, at least by the standard that I grew up and see. So we're talking about medical decisions that teenagers are making. I mean, they're just not reasonable decisions. You understand what I'm referring to, right? I mean, so I don't have to explain it any more than that. So what does it mean you're going to ask someone? So you'd have to ask someone who's in that stage of life, what do most people want to do? But if the whole world is on the autonomy slide and sliding down really, really quick, so what does that mean? So again, we'll leave that for now. So we've covered now the point that we get to the issue that pain and suffering are the absolute requirements in the context of a chaye shah. And from here, we can have a discussion. So looking at our watch and saying, this is how long it took to get to the point where you could say, now we can have a conversation of what we're talking about. And we've eliminated what we cannot talk about. Now that we're at this point, we get to the points of, what do you want to do? So we need some definitions. The definitions that we're going to need are going to be, is there a difference between a withdrawal and a withholding? That's going to be point number one. And again, this is found in Rav Steinberg's Refuah Halacha in great detail. And there's a fundamental difference between withdrawing something. In other words, a patient is on. Well, let's just make we're going to come to more details of it. But just in other words, a patient is on a ventilator. So you say, I don't want the ventilator anymore. That is essentially going to be withdrawal of the ventilator. Withholding says, do I have to go on the ventilator? Okay? Big difference in terms of halacha. They're not the same. So that's concept number one. Concept number two is, not all treatments are the same. some treatments are continuous, and some treatments, by definition, are cyclical. A cyclical treatment means that it has a beginning and it has an end, which means that there's an exit ramp. There's an opportunity to enter it. There's an opportunity to exit. Again, if you're on a ventilator, technically speaking, we're going to just say technically because it gets into details that I'm not ready for yet, but technically speaking, it's a continuous treatment, right? But let's say a person is on dialysis. So they go on dialysis Monday, Wednesday, Friday. Do they have to, after they finish their dialysis on Monday, they turn around and they say, honey, we're done. That's essentially a cyclical treatment. So we're going to talk about, we have to understand what they are. So anything that falls into that category, chemotherapy, radiation therapy, even pressor agents is considered. Pressor agents, just to explain to the non-medical crowd, is a patient is in a hospital. Their blood pressure is very low. They're in the ICU. And they're being placed on what we call pressor agents. In other words, these are essentially medications that are used to augment and to boost your blood pressure. Okay? The bag fills, and then when the bag empties, somebody has to take another bag of saline, 500 cc's, they're usually going to be on a medication like dopamine, put some dopamine, squirt it into the bag, and we continue that as well. Is that continuous or is that cyclical? That's the question. So a big chiddush, Rav Shlomo Zalman Auerbach, and this again, he told Rav Steinberg. He told Rav Steinberg, and this is how Rav Steinberg's father passed away. In other words, the question was what happens? So it was end stage and things of that nature. What was only holding him up at that point was that he was on medication, on a pressor agent, something like a dopamine in a thing. When the bag ended, Rav Steinberg asked Rav Shlomo Zalman Auerbach and said, would it be permissible at this point not to put in another bag? And the answer to him was absolutely. So they said vidui, they did whatever it was, and that was the end. And that's how it was. So that is the concept of a cyclical treatment. And that is an important fundamental concept between withdrawal and withholding, and something which is continuous and something which is going to be cyclical in nature. Then you have a third category. And the third category is, for some people, not a treatment, not a medication. It's basically fluids and nutrition. And what you can and cannot do, so this is easier if you just have a visual. So if you're looking with me at the handout, the guidelines are going to be, is it permissible to withhold? Yes, you can withhold anything you want, right? Now, withholding, you don't have to do things, and we'll talk about some of the details, but continuous and cyclical treatments. Can you withdraw any of them? So at that, you can essentially, withdraw in the sense that it is a cyclical, the way we've explained it, not midstream. And what's forbidden to withhold is going to be, of course, oxygen and nutrition, which has an asterisk next to it, is there. And the reason that it has an asterisk next to it, again, is as follows. Many years ago, the great Gedolim of Eretz Yisrael signed off on a letter that essentially basically said that when it comes to the following items, food, nutrition, they also included insulin and antibiotics, they didn't feel that was a treatment. That they felt that those were necessities of life. And essentially, they ruled that you must always feed a patient. In other words, today, a lot of times, we have families, patients, who they're not able to feed. Either there are issues of they cannot feed, there's aspiration risk, they don't want to feed, they just don't want to eat anymore. So the big question is going to be, what do you do? So the short-term solution is you put in an IV, but that doesn't last very long. Then you feed with TPN. That's going to last a little bit longer. TPN, total parental nutrition. You feed a little bit longer. But that's not a long-term answer. So what about putting in a tube? So you can first put a nasogastric tube in. It's invasive, but it's basically a tube inside. And ultimately, you put in a percutaneous tube. You essentially put in a peg, and you put in a percutaneous gastric tube. And in that way, the patient is going to be sustained. So according to the 4 major Israeli poskim that I mentioned before, that is something that they signed on a letter that essentially fluids and nutrition is not part of this discussion about withholding or not withholding or anything of that nature. And that was for many years the way many of the poskim said, and how far do you go, so on and so forth. Back to Rav Hershel Schechter and Rav Mordechai Willig, again, Rosh Hashiva at YU, they basically, essentially disagree on this point because they, in essence, would say that it's no different than any of the other cyclical treatments. In other words, if a patient doesn't want, then they don't. If they don't want that, then we don't have to go. So part of the 2 points are going to be, number one, what would someone else want in that situation? So if you were to ask, let's say, I'm going to make up a number, a 90x plus years patient, would you want this and things of that nature? And if the general consensus is that's not what they want, then according to Rav Schechter's Psak and Halacha, this would be something that a person or family would not be obligated to do so. So this is a major, major source of contention because it's really one essentially requires ongoing natural, not natural, even non-natural ways of feeding a patient, and we can discuss, what the implications of that's going to be, versus an approach which says, if they don't want, and they don't want, we don't have to. So the level of aggressiveness, if you want to call it, is controversial in terms of the issue of fluids and nutrition. So at this point now, in the time that's remaining, that I want to go through some of the more classic quick, sort of the issues that come up in day to day, but this is really the background. I mean, we could stop here, okay? In other words, this is essentially what goes into decision making. So no one should leave here thinking, I hope not, that now we know how much, because you need to have 3 people involved in this. You need to have essentially the family input. In other words, it is important to know what the patient wanted. So advanced directives is extremely important, whether you call it an advanced directive, living will. What would the patient want if they would be in that situation? Because there is a certain degree of autonomy, according to Rav Moshe Feinstein, if a person is at that level of life. And if they can't speak for themselves, then their advanced directive or their surrogate should be able to step up and say, this is what so-and-so wanted. I know that because we've had a conversation. But if you've never had a conversation with anybody, right, and if it's an emergency, it's an emergency. But if it's just delayed because you didn't want to have an ayin hara, then what do you do now? You don't have the patient's autonomy. You are the patient's mouthpiece. So what do? You ask the Rav? Yeah, okay. Not saying no, but then what? You're just going to say hands up, whatever the rabbi wants to do. So there's some actually fascinating stories that I just want to say this, and I don't mean this in any disrespectful way, but I think it's important to say. Take a glass of water before I drink this. In life, everybody knows their level of expertise, okay? Or should know their level of expertise, okay? I'm a pediatrician. I know my where I know, and I certainly know what I don't know. And in every area, you have to know. I mean, is the knife kosher? Is the not knife kosher? That's great. If you're a rabbi, terrific. But you're practicing outreach, and the last time you had a shaila on a kosher knife was 35 years ago when you did your bechinas on Yoredeya. You should not be paskening a shaila on knives, kashrus of knife, just because you have a rabbi attached to your name. A doctor who knows nothing about end-of-life care, doesn't work in the thing, but is a lovely dermatologist and has no clue whatsoever, should stay away from these. Rabbi Jason Weiner tells a story that he was there was a story in LA. He's the rabbi at Cedar Sinai, that they went to the Rav and they said, this and this and this and this, and they said you can't have a DNR. So they came up in conversation. Do you know what a DNR is? No, what's a DNR? What does it stand for? In other words, the level of ignorance can be so high at some times because if you take an approach that just says they have to do everything, I don't want to know about anything, the message will be and should be repeatedly, you need to find people that know what they're doing. And again, just because a person is a doctor does not mean that they know what they're talking about, right? And certainly it's, again, with kavod and with respect, the rabbi needs to be someone that deals with these kind of issues. And there are rabbanim in all the cities that deal with it, and there are rabbanim that just, again, not that they do, just, again, like I said, we don't ask an NCSY rabbi end-of-life questions, and I don't mean anything, again, when he's, just I'm saying that from a practical point of view. Now, in the next few minutes, what we have, and again, I'm happy to either go a little bit longer, a little shorter, but I want to just, speak out one here, again, a Ramah. There's an important Ramah that will fundamentally, put for us into context of what is the halacha with regards to this idea of, do you have to actually, everybody know what I mean by intubate? So intubate is putting a tube down the person's throat in order to put the patient on a ventilator. So, do you have to go to the hospital? When a person goes to the hospital, one of the first questions they ask is, are you a code? Are you not a code? And if a patient is experiencing difficulty breathing, do you intubate? The problem with intubating is as follows, is that if you're on the ventilator, traditionally speaking, you have only there's only two exit ramps from that. Either you get better or you don't. In other words, you either get better and you survive and you don't need the tube anymore, or you don't get better and you die. The other choice is that you linger on in this on this machine for many, fill in whether it be days or weeks or months, and then you get onto a tracheostomy and so on and so forth. So therefore, the decision about putting a patient on a ventilator is probably one of the most important decisions, and one needs to be very cautious and careful about. Now, it hinges on a Ramah. The Ramah tells us the following. I'm not going to have time to read the details inside, but I want to tell you that there's the concept of what is referred to as siras hamonea. So the cases that you have here, a goses, and it's called a goses zman aruch, which Rav Steinberg told me that the term goses zman aruch doesn't appear in Shulchan Aruch any other place. Everywhere else you find that it's a goses. Here, the Shulchan Aruch says, the Ramah talks about a goses zman aruch. And the suggestion that he wants to make a diuk in this idea is that perhaps this is talking about even a chayisha, because after all, a goses we don't do anything for. But nonetheless, it's a goses, and at that point, there is a wood chopper who is banging outside. And every time the wood chopper bangs, the patient kind of wakes up. But he is in the throes of death. He is at that point. Can you ask the wood chopper to stop chopping the wood? That is the case that we have here. That is called siras hamonea. All you're doing is you are withdrawing, right, essentially the thing which is prohibiting the person from passing on, right? So the fundamental question is, when a person is on a ventilator and they're essentially at that point in life, do you look at that as saying, well, it's the ventilator that's keeping them alive, and it's no different than the wood chopper? Again, so everything that we're going to talk about now in terms of the details is a machlokes, and that's why the rabbi and the doctors have to, it's not one perspective. There are many perspectives, and you need to basically say, how and where do you align yourself with? So in terms of do not intubating, again, I'm giving you detailed notes, and you have them there, but essentially the summary of the great gedolim that we have, had and have, Rav Shlomo Zalman Auerbach, Rav Usher Weiss. I want to read you Rav Usher Weiss's because he's currently alive. You can ask him a shayla today. I did. And he comes to the medical conferences. His rule of thumb is that you're only required to intubate a patient if there is a chance that they will eventually recover. In other words, this is a medical decision that you have to go into. It's not full steam ahead. In other words, if you're not going to recover, there is no obligation. Again, not my story. This is from Rav Usher Weiss. Similarly, from Rav Sternbach, Rav Moshe Feinstein, they all align very, very much along the same way, that in terms of this idea, do you have to intubate? Okay? I'm going to skip the whole portion part about the disconnecting from the ventilator because I've already laid it out for you. According to some poskim, they will see it as the wood chopper. In other words, it would be permissible. That is Reb Chaim David HaLevi in the Aseh L'Charav. It's also Reb Zalman Nechemia Goldberg who is of that opinion. Majority opinion, just to be clear, once you're on the ventilator, they don't want to take you off the ventilator. That's just the general rule of thumb. I'm going to finish up and then I'll take questions happily. DNR. This is really, at the end of the day, probably the biggest issue people come to the hospital. Now, I want to just explain, again, DNR means you come into the hospital, you check in, here's the OHIP number, is your, whatever, fill in the blank, mom, dad, are they a code? DNR means that in case the heart will stop, which we said that is how people die, the heart stops, right? Do you want the medical team to be summoned to start compressions and to continue to try to revive the patient? That is what the question is being asked here. So a couple of caveats, first of all. CPR, and you have it in your notes, it helps when the heart is the first organ to fail. In other words, if you have a young patient who who falls on a football field and they're rushed into hospital, there is presumably nothing wrong with the patient, anything else. Right now they've suffered a cardiac event. So that is very different. But so CPR will help when it's the first organ to fail. But when the whole body is falling apart, the patient is on dialysis, the patient has cancer, has all kinds of different issues, the heart is going to be the last organ to fail. And now what you're trying to basically do is just prolong all of what you have on board. Point number one. The biggest issue that people the critique is going to be, if they say DNR, it means that the hospital staff will not treat my loved one. There is a lot of truth to that statement. There's no question. But is that enough of a reason at the end of the day to come into the hospital and say that you don't want a DNR? This is a difficult question. We can spend a lot of time, people will have anecdotes and things like that. I've attended many of these shiurim and lectures and things of this nature where people make this as the central case. They make this the motif. This is what the problem is. You know why? Because if you agree to a DNR, if you agree to a DNR, they don't look at you, they dismiss you and things of that nature. There is definitely some element of truth. I rounded on patients, I know that, people are thinking, there's an element that it's on a weekend, is busy, and the patient who's a DNR, unfortunately, is one of the lower ones on the priority list. Nobody can deny that. But on the other hand, that cannot or should be a reason, in other words, if that's the only reason. And there is a tension in the medical world, there's going to be. But there's also the other tension, which is family comes in, they don't want a DNR, and now the medical staff are looking at this family and saying, what is with this family? This is like the wrong medical decision to do. So you're really between a rock and a hard place. But those are the social and the medical issues that come up. The halachic issues are going to be, is it permissible? So the parameters for that are going to be, surprise, number one, you can halachically, that's all I'm focusing on right now, focus and say that you don't want to sign a DNR. That means that you are going to write a DNR. When is it permissible for halacha, for people that are halachically minded to be able to say they want a DNR? So again, it comes from the Nishmas Avram, comes from the Igros Moshe. Number one, the expert medical opinion has determined that the patient is terminally ill. We've defined terminally ill already, right? So we're not talking about anything except for those 6 months, 12 months with a diagnosis and pain and suffering with no chance of cure. Number two, the patient is suffering. There needs to be that element. It could be a physical or it could be an emotional. According to some of the poskim, if the patient is unconscious, that's considered pain. Okay? And the intervention will only extend the Chaye Shah. That is going to be the principle that we are going to see here. So if someone says to me, my rabbi says you cannot do a DNR, just refer them again. You have the sources, you have them inside. It's there. You don't believe me? Nishmas Avram. You don't believe me? Igros Moshe. It's there. There are parameters to do it. Where it's applied and where. But for someone to say, we don't do DNR in Jewish, in halacha, either that's basically saying one of two things. To give the person the benefit of the doubt, they're taking the opinion of the Tzitz Lazer, Rabbi Bleich. They're taking the opinion that life is infinite and we will pursue it either way. But if you're taking the opinion that life is valuable, but there is a limit to it in terms of what we can do, and you're following the steps of Rav Shlomo Zalman Auerbach and Rav Moshe Feinstein, then absolutely there is room for this kind of a thing to do.
You have three conditions for DNR?
Yeah. Palliative sedation. It comes up all the time. The patient is in pain. Can you give them some morphine? So the answer is, of course, morphine will help. What's the side effect of morphine? It reduces your respiration. So here, what happens is, again, you have to know who you're playing with and who you're talking to. So if medically speaking, they're going to say, we're going to give your granny some morphine. Nudge, nudge, wink, wink. We'll take care of her. Okay? How much morphine? How much? So halachically speaking, that is called the double effect. The double effect is essentially like a side effect. You know what you want to do. But if the intention is to take away the pain, says Rosh Shlomo Zalman Auerbach in great detail, if the dosages in and of themselves, individually, will not kill the patient, but you know that cumulatively over time it may reduce it, you're still allowed to do it because pain overrides all. And you can treat it. The only thing you cannot do is knowingly say that this dosage will kill the patient. But the idea to treat a patient, to care for their pain is halachically mandated, again, by the greatest of the poskim that we have. And again, I leave you the sources inside to be able to have with references, so if anybody questions it, again, found in Shlomo Zalman Auerbach's work, in the Minchas Shlomo, and that is extremely important. So, you know what? Praying for death is we'll leave that for another topic. It's now coming to 9 o'clock. I'm going to pause here. If there are any questions, now would be a good time to do that. But I want to just at least, wrap up the lecture part of it by saying the following. Number one, dying gracefully is possible within halacha. There's no question at all, it can be done. Unfortunately, if one, and again, it all very much depends on what it need not be a great battle. First of all, one has to align themselves with one of two values. One is that life is valuable at its infinite, and we will do everything we can, and that could also be a graceful dying death, albeit that your ribs are going to be crushed because you have a DNR in place and you are whatever age you are and you are frail. But if that's what the halacha requires according to those poskim, you need to be able to go there. It's going to be a definition of grace. The definition of grace is what's going to be a decision, right? In other words, someone will look at it and say, that's not graceful. On the other hand, a person will say, it's a beautiful thing. Every second counts. So that's point number one. Most important is credit to everybody that's here. It requires planning. This is not something that people want to get into a situation where all of a sudden it happens and they don't know what to do and they don't know who to turn to and where to go and what to do. So it requires planning, it requires discussions. I think I've alluded to the fact that you need knowledgeable players involved. And just titles is not enough. You need to have people that really understand the sugya really, really well. And as you can see tonight, I'm not giving it any sort of one psak or another. One has to be comfortable. One has to know what's out there in terms of the menu to be able to say, this is my Rav who I've chosen. I've had a conversation with him. But if you've never had a conversation, just because he's the rabbi of your shul, whether it be here, there, or somewhere else, you need to know, where do they stand on these issues? Because if you as a patient, one day, God forbid, it's going to happen to the autonomy issues, is that what you want? If you've never had a conversation, what are you going to do? Tell your children, speak to? So these are the hard conversations. So in terms of before I tell you, there's phenomenal resources that are now coming available, and I do want to make a very important plug for Ematai. Ematai, run by Rabbi Shlomo Brody, is a phenomenal organization, and what they're essentially doing is essentially making discussions palatable. They're making those discussions meaningful and important. And I encourage you to go onto their website. I encourage you to download some of the information that they have, because they have these work little books. And it sits down with a family. No, you're not going to do it on a Sunday afternoon, but you're going to want to do it at some point in time to plan. And you're going to want to have this conversation. It's going to say, in the event of X, what will we do? And this is not cookie cutter. This is not, nobody can leave here saying, I want this, I want that, I don't want. It's concepts. In other words, where do you stand at this age today with where you want to see your end? Is yours going to be infinite life and, all that's for you, that's what you want? Or you want to avoid pain and suffering, like many people will. I'm not going to say even most, but many people. But you have to tell that to somebody. Otherwise, you're at the mercy of someone making that decision for you. And you don't know who that decision is going to be. Because, God forbid, if this is going to be when you're 120, and that's 40 years from now, and, your rabbi's not in town anymore, or your rabbi, you need to know, they need to know, everybody needs to know. Ematai has a work plan. They have a discussion little booklet that helps people talk about it in a way that is useful. And think, just in case you're saying I'm biased, there's also Chaim Aruchim. Go online, you look up Chaim Aruchim. I would say an organization that is much, much more in line with the first opinion of what it is. Full steam ahead, all things that we want to do, and there are many types of things. So for those that are comfortable, again, but still the conversation has to be there. So we'll close with Rav Moshe Feinstein's really an amazing statement, which is as follows. Rav Moshe writes in Igros Moshe, Choshen Mishpat, he writes at the end of this very, very lengthy tshuva, he says, and I've translated this into English, and I've left it in your notes because it's that worthwhile. I have devoted lengthy responses to these questions because they involve life and death decisions and often lack the clarity that would enable one to make a proper halachic decision. It is, therefore, important, very important, to utilize the services of as many learned sages as are available, to consult as many physicians as possible, and to arrange for rabbis and physicians to discuss each case thoroughly so that with the help of Hashem, a proper decision can be reached. Cannot be said any better than that. That is the only way to look at this thing here. So what may turn out to be a topic that is very, very challenging and difficult, if approached in a very, very delicate and sensitive way with our family, which means both directions, parents, children, have that conversation, it would bring really a lot of nachas, and there could be the misa of Moshe Rabbeinu that he desired, and he thought that it was a wonderful thing to have.